Welcome back to the Thinking Mind podcast, a podcast all about psychiatry, psychology, psychotherapy, and related topics. Today we're in conversation with Professor Anthony David. Professor David graduated from Glasgow University in 1980 and trained in neurology before becoming a psychiatrist at the Maudsley Hospital in London. He has a master's degree in cognitive neuropsychology. He was an honorary consultant at the Maudsley from 1990 to 2018. And he was the Vice Dean for Academic Psychiatry at the Institute of Psychiatry, Psychology and Neuroscience from 2013 to 2018. He has a wide range of interests, including schizophrenia, neuropsychiatry, medically unexplained symptoms, and neuroimaging. In 2018, he joined University College London as the Director of the Institute of Mental Health. Today we discuss his 2020 book, Into the Abyss, A Psychiatrist's Notes on Troubled Minds, which explores topics such as eating disorders, psychosis, suicide, and traumatic brain injury. We also discuss his path to psychiatry, why it remains a controversial discipline, some of the important lessons we can learn from Scottish psychiatrist R.D. Laing, the difficulty and importance of applying the biopsychosocial model to the patients we see in psychiatry, the role of meaning in a person's life, how the role of psychiatry in modern society could be changing, and much more. Thank you for listening. If you like the podcast, there's a few ways you can support it. You can share it with a friend, give us a rating, follow or subscribe on Apple, Spotify, YouTube, or wherever you listen or watch. Or if you want to support us further, you can check out the Buy Me a Coffee link in the description. In addition, if psychotherapy is something you don't want to just think about or talk about, but maybe you want to try for yourself, I'm now offering private one-on-one psychotherapy sessions, both in person in the South London area and online. So if that's something you're interested in, you can email me at alexcurmitherapy@gmail.com. Thanks for listening, and now here's today's conversation with Professor Anthony David. Professor Tony David, thank you so much for joining me today.
My pleasure, my pleasure.
It's really nice to have such a prolific researcher on the podcast, and we're going to discuss your views on psychiatry, some of your clinical work, but also your book, Into the Abyss, A Psychiatrist's Notes on a Troubled Mind. There's a lot that I want to talk about today, but firstly, I'd like to ask you, why do you think psychiatry remains such a controversial medical specialty?
Well, I think it's very misunderstood as a specialty. And one of the motivations for me writing the book was to try and give a flavor for what it's really like, how it's very much a part of medicine, and shouldn't be seen as that different from other branches of medicine, although, of course, they're all different in their own way. So I think that's one reason. I think, but everyone's interested in things like motivation, the effects of challenges in life, why some people seem to do well, some people don't seem to do well. And of course, we're all touched by people with mental health problems in our families and our friends. You know, everyone knows someone who's had difficulties. In fact, most of us have had our own difficulties at some point in our lives, even though we're not quite always able to talk about it in the way we would about a physical illness. So those are the kind of differences and similarities between psychiatry and other branches of medicine.
Yes, I think you're right. So there's a combination of misunderstanding, misconceptions, but then also everyone has a stake in it. Everyone has a vested interest. So lots of, when I talk to people, lots of people will have an inherent interest in psychiatry in the way they wouldn't have in, for example, hematology or orthopedics. But then the misunderstandings, and also I think maybe what people project onto the specialty and what people project onto psychiatrists, I think leads to a lot of controversy, but then also the tremendous mystery. What do you think are the really common misconceptions people have about mental health conditions?
Well, I think the main thing, the main misconception is about what psychiatry is and what psychiatrists do. Um, I think a lot of people still have this image of the psychoanalyst with the couch, and an entirely talking therapy based approach. And of course, talking therapies are hugely important in psychiatry. But as I said before, we're a branch of medicine. And I think that's really where most of the misunderstanding comes. And of course, it's our bedrock in psychiatry is the biopsychosocial approach. And it's actually quite a difficult thing to convey to people. It sounds like, even within the profession, it can sound like, well, it means everything and it means nothing. It's kind of very vague. What are you trying to say when you say, well, you believe in a biopsychosocial approach? But actually, it's really very important and quite profound when you think of trying to understand an individual's personality or motivation. And in every case, we know something from the neurosciences that can help us understand that, from the brain biochemistry, from the brain's wiring. There's something about psychology that helps us understand it, from the way we attend to things, our memory, how that's filtered. And then, of course, we're all social beings and we're influenced by what our peers say, by ideas in the culture, by our shared beliefs. So almost any symptom or condition has to address all those elements. And that's really difficult. And the thing about the psychiatrist is he's not biased towards one or other. He's got to decide, he or she's got to decide which is the most relevant for this particular case in this particular context. But there's no hierarchy of explanation. And that's actually, I think, what makes psychiatry so fascinating. But it's difficult, and it's hard to convey to people that that's kind of what we do.
And you have to deal with a lot of uncertainty because in almost every case, the extent to which there's a biological weight versus a psychological weight or a social weight is unclear. So to be a good psychiatrist, you have to have quite a strong ability to tolerate uncertainty, I think.
Yes, absolutely. I mean, perhaps it's true that the evidence base for our work is in some cases less secure than hematology that you mentioned. So we do have to accept that, and that it's a work in progress. But yes, this balance of different influences, judgment comes in there. And I think in clinical practice, you have to just try and make the best decision you can and try and share the uncertainty with the patient in front of you. Not pretend that you, as the clinician, know everything. And that's one way of dealing with uncertainty. The other thing is to take it away into your research and try and answer some of those questions through research.
Yes, and you've done a lot of research. So you've published over 650 peer-reviewed articles, and part of what I'm interested in exploring in this podcast is career development and what drives people. What's driven you to have such a prolific career, to produce so much at this level?
Well, I've been very lucky. I've worked in places where research was really highly valued, and I've had some great colleagues who I've followed and worked with, and that's been enormously satisfying and great fun. So yeah, I came to research when after I qualified as a doctor. I wasn't one of those students who was always in the laboratory, who had a strong science background and knew that they wanted to do research. It was only once I faced clinical problems that I realized that there were there were so many unanswered questions, and that that my, if I had some skill, it was in trying to span lots of areas and have a broad understanding and see which one might be relevant, rather than being a real specialist in any one thing or with a particular skill. I think nowadays research has become more sort of hyper specialized. And I think one probably does need to acquire a particular skill or detailed knowledge in one area, and then, become part of a team that applies that to a research problem. I think that my career has seen a slight shift away from the kind of generalist who's got one foot in the clinic or one foot in the laboratory to really needing full-time kind of professional researchers, although they've got to talk to clinicians to understand what the problems are and to make sure that they're not going off in some tangent, which does happen. So that's how it came to me. It was very much grew out of clinical work, and then I found that I really enjoyed research. As I say, just the people I was lucky enough to work with, I found them just so stimulating. And the research world does have its benefits. Traveling and presenting your work is tremendously exciting. And I think full-time clinical work can be quite a burden after a while. And people often find something else to take away from that. Sometimes people get interested in management. Sometimes they just develop other interests and careers. But I think clinical research is a great way of dealing with it. It's a great balance between, keeping your interest and your sort of compassion alive, and also, working with scientific concepts, with producing data and analysis and writing it up. So to me, it's a perfect combination.
What are some of the most interesting answers you've been able to discover through your research? You say your research was a direct response to some of the mysteries and the questions that you faced in your clinical work. And that's obviously a good pragmatic approach. I think you alluded to the idea that sometimes researchers can be kind of siloed off in the academic world, too detached from the sort of hard realities of clinical problems. So it's really nice that you're able to combine the two in that way. And what are some of the more interesting answers you've been able to stumble upon through your research?
I guess my core interest that has sort of kept me going over many years is this question of insight in psychiatry, especially in people with psychosis. And I just became interested in it because it was a term that people used in the clinic, and they used it in different ways, and people sort of thought this was something important, but then when you asked them to define what they meant, they struggled. So I think what I try to do is sort of conceptualize what insight really means, and it clearly had different elements. It was a sort of multidimensional construct, but there's something that you could define. You could come up with scales where you could measure it in a way that was useful for research. You could show change. You could show correlations, some of which were quite surprising. And then you could start to dig into whether there was a kind of neuropsychological element to insight, which, there clearly is. On the other hand, it can't be explained entirely like that. Like I was saying before, there are obviously social, cultural, and psychological elements to what we call insight. But it's also very practical in that it predicts a lot about a patient's journey in terms of whether they're going to be able to take, to benefit from treatments or to reject them, to end up being coerced into treatment rather than seeing the need for it. Their relationships with their families, etc., the burden that carers find is very related to insight. So this one concept kind of spread and took me into all sorts of different directions. So that's every one of those directions has been illuminating. So that's been a sort of major interest of mine over the years.
And how would you explain the concept of insight to someone who's new to psychiatry or someone who's a layman?
Yeah, well, I think it's about a person's awareness of their own condition is what's essential to insight. But that can be at the global level. Do I have something wrong with me? When I look at my own behavior, my own beliefs, are these shared by other people? If not, are they wrong or am I wrong? So trying to answer that question as an individual, I think we start to understand what it's like to have a disorder and then to struggle to have insight into it. And then, so that's the sort of general case. But then there's the specific cases of say, hallucinations. How do we know that something we hear or see is real? And again, this is something that everyone can understand. Sometimes you wake up from a dream, and in those first few moments, you're really not sure, was that a dream or did that really happen? We can all sometimes think we heard somebody calling our name, and we look behind and there's nobody there. Was that in our imaginations, or did we hear something? Did we mishear something? And we can, many people can imagine pictures in their minds. Not everybody, as it turns out. And sometimes these are very vivid. So psychologically, we must have ways to distinguish between what our imagination and what we're seeing in front of us that other people can see. So the second element of insight is about the specific nature of beliefs and perceptions rather than the overall, is this a condition or an illness that needs treatment? It's, did this thing that I perceive or believe, is that really shared by other people? Is it really real? And then the final element is all these things, do they need treatment? And again, that seems like it's a very kind of specific and rather modern idea, but we don't necessarily mean, does it need medication, for example, or therapy? What we're saying is this state I find myself in something that needs to be managed or corrected, or I need help with? So in that general sense, there's something that I need restitution from. So those three elements, I think, are the key elements of insight.
And we know that it's very common for people with a severe mental illness like schizophrenia or bipolar disorder to lack insight, to lack the awareness that they, like you said, that sort of global awareness that something is wrong, that second tier that perhaps a hallucination isn't a reflection of outside reality, and that third tier that perhaps they have a problem that would warrant some sort of specialized attention, some sort of medical attention perhaps. Why is it the case that persons with these kinds of conditions so often lack insight?
Yeah, well, that's the big question, and there isn't a simple answer, because some people, even with, say, schizophrenia or dementia, they do have insight. So a person with schizophrenia will say, I hear these voices, they feel very real to me, but I know that's part of my illness. I know there isn't really a person out there. It's just that, I can't not hear them. Or, I know I'm not getting on as I should be in my life. I'm troubled. There's something amiss. And yet I'm still trying to carry on. I know that the medication helps those voices, but sometimes I struggle with, having to take it every day and to feel that there's something wrong with me. So I think it's very easy to understand why people struggle with it. But we do find that there are brain mechanisms that help all of us reflect on our states of mind, on our perceptions, give us confidence that that was real, that was not real. I made a mistake. No, I'm very confident. So that's now studied by psychologists under the heading of metacognition. So that's something that everybody has, and there are brain networks that we know are involved with that. Particularly medial frontal systems seem to be particularly involved with metacognition. So we have something that in the healthy person we're beginning to understand how it works, and so it's not a big leap to think that, well, if that system isn't quite working right, or if it goes awry, maybe that's what happens when someone has a severe mental disorder. And so that system doesn't quite keep them on the straight and narrow, and it misleads them into false beliefs and false perceptions.
Yes, and as you say, metacognition is something we all have to greater or lesser degrees. And when we think about insight as a concept obviously doesn't just apply to people with a mental health condition. I work a lot in the psychotherapy world, and we think of a very broad definition of insight. Everyone has some degree of insight, the ability to, for example, be insightful about the overarching patterns of their life, what situations they may fall into, common mistakes that they make. I recently released an episode on self-sabotage, all about this topic, the fact that we can continually make the same mistakes over and over again. So I think based on my clinical experience, I would very much view insight as a spectrum, and we all have it to some degree or another. But my question is, do you think insight is something that can be trained and improved upon, particularly since even patients with more severe mental health conditions, often after a certain number of admissions, after a certain number of crises, that's when it begins to sink in that they may have a problem. And similarly, it's the case with psychotherapy clients that may take a number of years, but eventually certain insights about themselves may land. So do you think that insight is something that's neuroplastic, something that can be trained and developed, strengthened like a muscle?
Oh, very much so. So there are metacognitive therapies that kind of target that ability to reflect on one's mental state, consider how we might be prone to biases or errors, and sort of point those common errors out to a person and help them apply them to their own lives. So some of those therapies look quite promising, even when people with bipolar disorder or psychosis. But also our medications to treat psychosis, we know they're effective, not for everyone, but for many people. And when a person is treated, their degree of insight changes. So there's something about the psychotic state that impairs insight, and that when that is improved, the insight returns. Of course, it's not a direct correlation because, like we say, you can have people who have very florid hallucinations and delusions and yet still understand that there's something wrong. And similarly, you can have people who are not in a florid psychotic state, and yet kind of don't process their previous behaviors. They don't sort of lay them down as something to learn from. And you have this idea of a ceiling over, and the person just pushes that to one side. That was then, and this is now, and there's apparently no learning from experience. So that's the other side of the coin. But yeah, I think insight is something that one can work on, and there are therapies that can aid it.
Yes, and probably it's also worth mentioning that very often developing psychological insight for anyone is not a pain-free process, especially when it's about yourself, an illness you may have, difficult patterns, and as psychiatrists, we tend to maybe unconsciously think of insight as just good, because if someone has insight, that means they're going to be a bit more cooperative and their prognosis is better, and all of that's true. But the process of coming to understand oneself, for example, understanding that one has a severe mental health condition, it's a painful process. There's a lot of painful realizations, and often that compartmentalization, that sealing off you described, is a valid way of the person protecting themselves, protecting their ego structure, however you want to phrase it. And in the short term, it can be useful because it can prevent, a total sort of psychological breakdown. But really, it's in the medium to long term, I think, where insight really has its value, and where kind of it's worth that short term pain because it gets you those better results over the long arc.
Yeah, I mean, Aubrey Lewis, who founded the London Institute of Psychiatry, wrote a paper in 1934, 90 years ago, and said that insight was a painful struggle, just as you've said. Because yes, when we're asking a patient about insight, we're always asking them to accept something bad. I'm ill. I was wrong. It's never something good. So you can understand the human need to try and avoid making that decision or to put it to one side. And that's why there's a very close link between mood and insight, which I think a lot of people misunderstand. So what we find is that a lower a person's mood, the more depressed a person is, the better their insight. Now, a lot of people think they know the reason. They think, well, obviously, if you understand and accept that you have an illness, that's a very depressing thought, and that makes you rather depressed. And, that's conceivable. But another way of looking at it is that when your mood is lower and you've lost the sort of biases to see the world in an overly positive way, and you're looking at it more realistically, what some people call depressive realism. When you're a little bit low and you're seeing the world for what it is, you then are able to see your own imperfections as well as other people's and the world's imperfections. So it's happening the other way around, that your lower mood allows you to develop insight. So that's one of the real conundrums about insight that we're still trying to understand.
Yes, and that also implies that psychological health also includes a small dose of delusional optimism. And I could see that because, ultimately, we've been thinking and talking a lot about evolutionary psychology on the podcast. And I don't really think our brains evolved to be purely reality oriented. I think a lot of our brain processes have evolved to be reality oriented, but part of the function of optimism isn't just to sugarcoat things, it's also to simulate a sort of a potential reality that could be. And in fact, when people are in an optimistic mindset, it's often oriented towards the future. It's an optimism about something that could happen. So I think a lot of our brains are evolved to figure out how things are in the moment, but then also this ability that's kind of unique to humans, or maybe humans and a couple of other species, to imagine a potential reality. And that's part of the problem with depression. You're probably really well oriented to your present reality, as you described, but you're losing that ability to imagine something that could come into existence, not 100%, not with 100% certainty, but something that could happen, And that's so important to drive us forward in our lives, and also obviously to make our moods better.
Absolutely. I think that's absolutely right. And in fact, I think I try and get into that in one of the cases in my book, Losing My Religion, where it is about this idea of depression taking away a person's ability to see a positive future, and that being so devastating.
Yeah, that was one of the most interesting cases. Do you want to just walk us through that case? What happened?
This was a patient of mine who had a history of depression, and he developed a depressive disorder. He also had quite a strong faith belief, which didn't seem to be particularly relevant in his case. But it was clear that he was very depressed. He had been on an antidepressant for many years, and it had been very helpful. But for whatever reason, he developed this relapse, and he was in the hospital. And I remember in a ward round, sort of just touching in with him, finding out where he was, how his mood was doing, and it seemed like he was improving, and he just let slip that, by the way, all this religious stuff, religious nonsense, yeah. He wasn't bothered with that anymore. He was just going to get on with his life. And at the time I thought, oh, well, okay, as a super rational person, I thought, well, that's perhaps a good sign. Unfortunately, it wasn't, I think, in retrospect, a good sign. And this was in a way, it was a trap that many clinicians fall into in treating someone with depression, that the point at which they appear to be getting better is actually quite a dangerous and vulnerable point. And he was very, very keen to leave the hospital and be with his family, who he was missing, and that all seemed perfectly understandable. But as it turned out, on a sort of trial period of leave, he took his own life. It was absolutely devastating. Obviously, his family were completely devastated, and as a clinician, I felt terribly upset and felt that I'd made a bad decision, and the rest of the staff similarly. So it was sorry to start on such a sort of downer, but that's the reality of our work, that does happen. And the question is how we can learn from it. And I think it is about understanding a person's need to conceive of a future, and that I was drawn into rereading Emil Durkheim's classic work on suicide, and he talked a lot about the power of religion as a force for binding people together, for giving people a sense of purpose. Now, obviously, it's not the only thing that does that, and not everyone has a religious belief, but how that is a protection against suicide. And this is something that Durkheim found going back 150 years, and it's probably still true today. So, that was a rather sad story, but hopefully one that we can learn from.
Yeah, so I guess the lesson from that case is that a patient can change in a way that to us looks great. If we're super rational, if we're not so religious ourselves, doesn't seem like a big deal. But what happened with that patient is, for one reason or another, he lost a huge part of his meaning structure, his way of making meaning of his life, his past, and potentially his future, I guess.
Exactly. Yeah. Yeah. And there are sort of psychological theories that help us understand that as well. The idea of a overly generalized memory, where if you were asked to think of some happy events in your past, person who's rather depressed or at risk of suicide will only be able to produce general kind of memories. Yes, I remember, when I was at college being a bit lonely or being quite happy, rather than, oh, there was that time that we went to the park and we had a picnic and it rained and it was, those sort of specific memories are much more useful when you're trying to say, what's the purpose of my life? Where am I going? If you can draw on those specific instances, they're really powerful, even negative ones. But when everything is just a sort of gray generalization, that really, that's a sort of risky situation. It means that the person is sort of unmoored. They don't have anything to cling on to. And that's a sort of cognitive understanding of exactly what we're discussing here.
Do you think that given we have to face cases as complex as this, and I've faced similar cases, my clinical work, as psychiatrists, we have a duty to not just understand the medical science, the biology, but we have a duty to be to immerse ourselves in philosophy, existential philosophy of understanding the ways that people derive meaning from the world. Obviously, understanding people psychologically, getting a grasp of sociology as well. Do you think it's our duty to immerse ourselves in this, and at least be conversant in these different disciplines as well?
I kind of think so, but that's kind of a little bit of a bias. And in a way, when you think of, well, what's the ideal curriculum for a mental health professional? It's everything. It's the entire world of literature and art and poetry, as well as everything in neuroscience and everything in social science. So we're limited in what we can really take in and understand. But I think it's healthy that there is a strand of psychiatry and psychiatrists who are interested in the sort of philosophical, conceptual underpinnings of what we do, and in a way we rely on some of those people to simplify it for the rest of us and to make it relevant. In the same way that we rely on people who understand basic neuroscience and molecular biology, we can't all understand everything, but we do rely on them to sort of bring back from the underworld some nuggets of information that are important to us. So I think as a collective, we have to open our minds to all of these things. But, we're only human and there's only so many hours in the day.
Yeah, yeah. And on the other hand, I've done a lot of interviews recently with people very much critiquing viewing mental health problems through the lens of the biomedical framework, and that there are problems with it, can be too restrictive, can close us off from those other ways of thinking about things which we just mentioned. Can you make the case, perhaps giving a few examples, that the biological lens and the medical lens really is important when dealing with these sorts of problems?
Yeah, I think it's through stories, if you like, case histories, but they're really stories. And the case histories in my book, they're based on real people, but they're quite often an amalgam of several patients put together, and obviously they're disguised, but they are real deep down, and they are stories. And I think through stories we can sometimes understand the links in a way that's easier than by studying the basic sciences. But for example, there's also a story there about a person who suffers quite a severe head injury. He was a very keen cyclist, and he got knocked off his bike and had a really quite severe head injury, and in many ways made a very good recovery on the surface, but deep down, some very subtle changes had happened in the way he appraised himself and reality, in the way we've been talking about in regard to insight. And he developed delusions about not being really alive, that we attribute to Cotard and the Cotard delusion, as well as feeling that the world was not a real world and that he was in a sort of parallel world. It's a form of the Capgras delusion. So none of that would have happened, I'm sure, if the person hadn't had a brain injury. And you could see that certain systems had been put out of action, or connections between the emotional appraisal parts of our brain and the more rational, like we were saying, metacognitive aspects of our brain, that put it out of balance and led to those abnormalities. But the person still lives in the real world. He has a wife, he has a job, and so what I think a case history can tell you is how that physical damage and disorder can impact on a person's real life. So it needs both the neuroscientific understanding as well as an understanding of human nature and relationships to really help. And in that case, it was a kind of psychological cognitive behavioral approach that was tried to bolster the kind of reality testing that was somewhat helpful in his case in the end.
So he was learning to develop some insight as well, in a way that we described before. I mean, again, I've had a lot of these interviews where there's a lot of pressure put on the biomedical view of mental illness, and when we talk about it, I'll be the first to acknowledge certainly that there's a lot of mystery. There's an absence of biomarkers, but at the same time, perhaps one of the foundations for thinking for the utility of the biomedical framework is simply that there's a lot of evidence that our first-hand subjective experience of the world is mediated by this organ we call the brain. We know every organ in our body can fail, or its functioning can be disrupted in all sorts of ways, and there's no reason to think that the brain is exempt from this, and that there aren't lots of different ways that the brain that its function can't be disrupted, and that would obviously affect our first person subjective experience, even if we don't fully understand the mechanism. That's in principle is what is happening. Makes a lot of sense to me.
Of course, I mean, I can look in the book, and there's another case that I call "You Are What You Eat." And to cut a long story short, this is a rather unusual case, but in the end, it's a person who has an eating disorder. Now, I think that's a good example for what you're saying. So we know very much that the way we eat, the way we look at our bodies and our body shape is hugely influenced by culture and societal expectations, and how that it's different for men and women, and these are very, very powerful forces. But equally, the biological control of appetite is again absolutely fundamental. It goes, obviously no animal would survive if it didn't have a very strong inbuilt control of its appetite and eating. So here you have, I think, the perfect sort of example of how you can't really understand one without understanding the other.
Now let's take the opposite point of view. Where do you think the biomedical model of mental illness overreaches? Where is it too restrictive, or where is it not the best way of understanding a problem, do you think?
Well, I think, as we were saying, we should always think of the biopsychosocial model. And when people talk about biomedical, it's a kind of slightly loaded term. And it comes out particularly in cases where there's a, where there's a contested view about the cause of the condition. And often it's a case that that psychiatrists, mental health professionals are more willing to take a kind of more general view. So there are a lot of people who have physical symptoms, and it might be what we call functional neurological disorders or conditions like chronic fatigue syndrome, where the predominant symptom is a physical symptom. So we've got to understand what's happening in terms of physiology, and yet the individuals themselves begin with a rather narrow and restricted biomedical view. And the idea that there are other factors that lead a person to feel fatigue, for example, they reject totally. And partly because of a misunderstanding of what that means, and partly because they feel that any mention of psychological it means it's not a real illness, and those kinds of misperceptions, perhaps the stigma that they attribute to having anything that's mental health related is just too much to bear. And so there are individuals, not our profession, but there are people out there whose very highly restricted biomedical view prevents them really taking on board a more broad understanding that would actually help them. So I think in whosever hands an overly restricted view is never going to be is never the full story. But yes, I think psychiatrists sometimes make the mistake as well of relying too much on medication, too much on sort of neurochemical explanations, rather than seeing them in a context of the person's life story and of what's going on around them. And so yeah, there's sometimes too many people are on medication. I think this is happening now with lots of adults seeking a diagnosis of ADHD or of autism. And I think, although these are interesting areas, and it's quite appropriate for a person to consider those conditions as an adult, and it may well be that they were missed early on in their life. But I do get the strong sense that there's, although it's a sort of grassroots movement, partly it's what's called the neurodiversity movement, which is obviously a very positive and strong grassroots movement. But I think there are clinicians who overly subscribe to the view. Sometimes they're part of it themselves, and they see that a medical label or a medication is the answer, is a simple answer to a complex problem.
Yeah, and I think you see that with really common mental health presentations as well, like depression and anxiety, where we have a modern world that's increasingly turbulent, that's changing at a very fast pace. There are many factors in society which, if you just look at them on paper, you can see why they would cause a lot of mental distress. We're living a more isolated, atomized existence. Our food landscape of the past few decades is unrecognizable. Our lifestyles have changed so much. And sometimes I almost feel like psychiatry is being forced to take responsibility for the increased mental health difficulties people are experiencing as a result of all these seismic social and cultural shifts as well.
Yeah, I think that's right. But it's always complicated. So you see the number of people who are on antidepressant medication, and there are a lot of tabloid headlines that scream out, how it seems like everyone's on an SSRI, that there are too many people taking medication. And I think, first of all, depression and anxiety, they're common. And a lot of people are helped by the medication. But there is a feeling that some people are not really benefiting from the medication. They should be helped to stop. And at the same time, there are people who should be on medication that, despite the use and perhaps overuse of some medications, they're still not getting the medication that they need. It's not that there's just too much medication or over medicalization. It's a lack of precision in the way that we use these tools, these quite powerful tools. We're still missing people who need them, and we're still hitting people who really don't need them. So it's a complex. It turns out to be, like everything in our field, more complex than meets the eye.
Yeah, it's the hardest part of psychiatry, is to figure out which interventions would benefit which patient, and then even within that, there's complexity. Like, if someone has depression, you need to figure out, do you think antidepressants, among other things, are an appropriate option? But then we also don't yet have a sophisticated means of knowing which antidepressant to try, because some work so differently from others. And we have some means of trying to determine, which kind of antidepressants to try first, but they're not that sophisticated yet. And that's unfortunately where the remaining mystery within neuroscience persists, and why it's so important that sort of ongoing research happens to try and shed some light on this mystery.
Yeah, absolutely. And I think a lot of the research is trying to answer those questions. And my impression is that the researchers are a little bit too eager to claim a victory before they've really achieved it. We're always being told now that we have precision medicine, that we have personalized medicine, but really, if we're honest, it hasn't really made much of an impact in our field as it has in other fields of medicine, like cancer, etc. So we've got to keep trying. And use all the tools available, which are probably going to include better characterization at the phenomenological level, in terms of psychopathology. So those old skills, as well as genetics and large-scale data processing. So all of that, I think that's where research is heading at the moment. It's a big enterprise. It's sort of industrial scale, and I'm hoping in the end it will yield dividends.
Early in your book, you mentioned the Scottish psychiatrist R.D. Laing as being an early influence for you. What do you think is the value of his work, and why should young training mental health professionals still read R.D. Laing?
Yeah, he was a sort of hero of mine, and I went to the same university, Glasgow University, and he was a kind of because he was a radical and a critic against the establishment. I fell for that. We all are attracted to that, I think. But even later, when you can sort of sit back and perhaps reread some of those early works, you can see that there's some amazing insights in there. His ability to really unpack delusions and see them in their context, in terms of a person's sense of self that we were talking about a bit earlier. I think those were really they've lasted the test of time. He also wanted to humanize the care of people with particularly schizophrenia and people with chronic conditions. He didn't have the kind of training and the background to really be able to do that in a systematic way. But he tried. He tried his best, and they had some experimental wards setups that were much less restrictive and more humanizing. So those are, I think, the very positive legacies. I think there are some negatives. I think in his later work, he sort of questioned the whole idea of mental illness. He made some sort of slightly outlandish claims based on not very good evidence. So I think a mature understanding can see that there were some great achievements as well as a few missteps. But I'd still recommend people today to read, especially The Divided Self, which was his first book, and then, make up your own mind. See whether there are things in there that you think really enlighten you, and other things that perhaps you think, well, that doesn't really stand up today.
So importantly, you mentioned the humanizing of people with conditions like schizophrenia, psychosis, but also, and I guess Lang goes into this in The Divided Self, the decision as a psychiatrist to view someone's psychotic symptoms, such as hallucinations or the nature of their delusions, as an important set of data that you can use to understand the person's psychology, to understand where they're coming from. Like, there might be a reason that someone's having a grandiose delusion, for example, that they think they're uniquely gifted or that they're a prophet, versus someone else who has a paranoid delusion that people are against them. That these aren't just the kind of manifestations of a diseased brain, but they provide important clues as to a person's sense of self and how they feel they exist in the world. Am I getting that correctly?
I think so. I think that's a fair description, and yes, he drew on existential philosophy to try and understand what the person was saying in that context, rather than just saying this is just madness. And I think that was a very brave and brilliant step. I think now we can use cognitive science and cognitive psychology to give us another kind of perspective in terms of, like what we were saying before, reality testing, in terms of metacognition. That also gives us a way of understanding, for example, hallucinations and delusions, without just saying it's just rubbish, it's just bad data. There's something, it's telling us about how all of our minds work and how that it can sometimes take a turn. So I think that's a very valuable lesson that we can take from him.
I'd like to end talking a little bit about neuropsychiatry. You're a neuropsychiatrist.
Yeah.
What's the difference between being a neuropsychiatrist and a psychiatrist? What kind of patients or conditions do you see commonly?
Yeah, I mean, I think it's a small area of psychiatry in clinical practice, although its implications for the whole of psychiatry, I think, are very deep. But you could say it's the area of overlap between neurology and psychiatry. So it's the area where people with neurological conditions have prominent mental health problems, and that the neuropsychiatrist has to be reasonably up to date and informed about neurological conditions, especially brain conditions, and how they might give rise to psychopathology. And then accepting that the treatment approach might have to be slightly different. Might not be, but it might be. So it's that's the kind of main overlap. But then there is this other group of people who appear to have a neurological condition and whose main symptoms are in the realm of neurological conditions: weakness, paralysis, blindness. But they don't seem to have a structural cause in their central nervous system that explains it. And that's the area of functional neurological disorders. So the neuropsychiatrist has to deal with both, you might say, the both extremes. And it does create a really interesting area of clinical practice and research. But I say its implications beyond that are much, much wider. I mean, the interesting thing is that even in the UK, there's quite a few, only a few practicing neuropsychiatrists, whereas the potential need is really great. And I'm at the moment the president of the International Neuropsychiatry Association, and there are people in other areas of the world, some lower income countries, where there's one or two people who are the only neuropsychiatrists in the whole country, and there's a real need to support them and help them with training and other kinds of support. But yeah, it makes for a fascinating area of work.
Mm-hmm. So that second extreme that neuropsychiatrists deal with, where people have a symptom or symptoms that seem very neurological, like paralysis of a limb or blindness, as you mentioned. That's called functional neurological disorder. That used to be called conversion disorder back in the day. The idea that a psychological problem is converted into a physical symptom. Is that still the thinking, that it is as psychology converted to a physical experience, or has the thinking changed?
Yeah, I think the thinking has changed, but that remnant of that old idea going back to Freud, that still lingers on. But I think we do have a bit of a broader understanding that we don't really see these as psychological conditions, but again, a mixture, a biopsychosocial mixture, and that the way we deal with feedback from our body, so the sense that we are, the sense of effort that we have when we try and raise our hand or lift a limb, something's gone wrong with that feedback system, perhaps. So the person says, well, I'm trying to move my limb, but it's just not working. So that, what's going wrong there? Or the person with a sensory deficit who the physiological tests show that the brain is reacting to the external stimulus as you would imagine, but the person's conscious experience is different from that. So it really pushes the boundaries of what neuroscience can understand. But we find in that higher rates of other kinds of ordinary, if you like, psychopathology, depression and anxiety. We find that in some, but not all, people have had some history of trauma, and that has led to dissociation, this ability to kind of compartmentalize one's mind, to push things aside, to perhaps not feel things in the way that we would normally do. And all of those strands seem to add up in some people to ending up in a functional neurological disorder. But what we find is, rather than trying to seek out some mystery psychological explanation or trauma as would be in the Freudian days, I think just understanding physiological mechanisms and retraining an individual to learn more about the feedback from their body, to find different ways of motor programs for moving and walking, in a way that people with Parkinson's disease can sometimes carry out complex activities when it's just kind of automatic, but they can't do it when they set down to do it. The same things apply to people with functional neurological problems, and using those insights, I think, we can really lead to some very dramatic recoveries.
Okay, so in your experience, then the best approach is actually not to approach it from a depth psychology point of view, a trauma point of view, but rather just to retrain those physiological feedback mechanisms as you described. That's what the evidence suggests.
Yeah, that's right. First of all, there may not be that hidden trauma. And sometimes, our field has a history of making mistakes, and sort of finding a trauma where it doesn't really exist. We do that as often as missing ones that do exist. So, but that doesn't seem to be the key to recovery or helping a person recover. Of course, there may be a time later when a person wants to talk more about their psychological life as well as their physical life, but the priority is to get the person, out of bed or moving again or seeing again, and that doesn't require in-depth psychology.
What, in terms of just your general approach to patients, what would you tell a training mental health professional? Some of the maybe more poignant lessons you've learned about how to approach patients in general.
I think I benefited from a really good training where what we used to do was video record ourselves talking to a patient, obviously with their permission, and then we'd show those back to the class. And it could be quite excruciating sometimes, but because everybody did it, it felt good. And you could just see where you were missing things, where you had said something clumsily, or when something you said that you didn't really think much about really made a positive impact. So I think it's about being incredibly reflective of what you're doing, being very open to feedback and criticism, and see it as a sort of continual learning process. So I think that's the key to being a mental health professional.
Yeah, definitely. And I advocate recording yourself, role playing with your colleagues, and
Yeah.
videotaping that. I mean, I've even learned through the process of doing this podcast, recording myself on audio and video, talk about painful insight. It's
Yeah.
extremely painful at times, but extremely useful because it's this continual process of identifying the mistakes that you make commonly, which just makes it so much easier to correct. Uh, Professor Tony David, thank you so much for joining me today. Into the Abyss, psychiatrist notes on a troubled mind. I'd recommend whether you're a member of the public, someone training in mental health, or if you're qualified. Very accessible. It's kind of how I designed the podcast in a way, accessible so that anyone can get something from it, but at the same time, does not sacrifice depth. You go into a lot of depth. You will come out of reading that book very, very, with some really useful insights, very, very fascinating case studies. Thank you so much for talking to me today.
Well, thanks very much for those kind words, and it's been a pleasure. Thank you.
Thanks so much for listening this week. If you've got any feedback, as always, do get in touch. If you enjoyed the episode, why not give us a rating on Spotify or Apple Podcasts, because it really helps other people to find us. If you want to get in touch, you can find us on Instagram or Twitter, or you can drop us an email. And if you value the show more generally, why not buy us a coffee? Thanks so much.